Hello everybody, I'd like to welcome you to our today's ERKNet webinar. My name is Jens König from Münster and I have the great pleasure to introduce our today's expert, Professor Nicole van der Kar. Unfortunately, we just didn't manage to get Nicole broadcasted by her camera, but for everybody who wants to see her, I just printed out a picture of her. This is how she looks like, and we're just going to hear how she's going to how she's going to sound. Professor van der Kar is a pediatric nephrologist at the Amalia Children's Hospital in Nijmegen, and with a special focus on translational research on hemolytic uremic syndrome and C3 glomerulopathy. Since her PhD in 1994 on STEC HUS, she stayed in this field of research and has gained a long-standing expertise in clinical care and fundamental research to the molecular mechanisms and genetics underlying the pathophysiology of STEC HUS, atypical HUS, and complement-related disorders. Nicole has been involved in many international trials in HUS and C3 glomerulopathy, that won't work out today, and has organized several landmark meetings on this topic. Currently, she's leading the CURE-I-HUS study, a Dutch national observational study on restrictive eculizumab treatment of atypical HUS patients. Professor van der Kar is an active member in the International HUS Guideline Project by IPNA, the International TMA Nomenclature Project, and the co-lead of the ERKNet Thrombotic Microangiopathy Working Group. Today, Professor van der Kar will give us a lecture on a very specific form of thrombotic microangiopathy, the Streptococcus pneumoniae HUS. And before I forget again, please actively participate and put your questions in the chat box so I can read them out at the end of the webinar and Nicole will answer them for you. Nicole, thanks so much for being with us today, and we are very much looking forward to your presentation and your slides, and we are sorry that we can't see you.
Yes, thank you, Jens, for the very broad and nice introduction. And I'm really sorry, I don't know why the camera is not working. It says here that I share my camera, but the content is the most important thing. So that's what we will now share. I'm delighted to tell you more about Streptococcus pneumoniae hemolytic uremic syndrome, or mostly maybe you call it pneumococcal HUS. And the next talk will be, let me see, I have some questions first, because I think I really would like to know my audience, a little bit, and to ask you, how many patients have you diagnosed and or treated? And this is the poll. And then I know I get some help from Vanessa, I guess, probably. The poll is open. She will share it then, because I'm curious. Either it could be very well that you see 0 patients, or less than 5, less than 10, and it would be extremely exciting if you have seen more than 10 patients. So I think
I will start the poll question. So it's like about 30 seconds left.
Okay. So I will wait, because you have to think, you have to calculate. I can understand. Maybe not that difficult. I can ask the moderator what his selection would be. Jens,
my selection would be 2, which is less than 5.
Okay. Yeah. I imagine that the majority would have this.
That's in fact true. We have 38% for no patients so far, 51% for less than 5, and there's 5% each for less than 10, and 5% for more than 10. So maybe we should identify these persons later in the question round.
Yes, maybe they are the most experienced one. I guess my experience will be C, less than 10. So let's see. Well, today I will talk to you about epidemiology on the Streptococcus pneumoniae and its transmission. I will talk a little bit on virulence and pathogenicity, of course, on vaccination, and then we come to epidemiology of the pneumococcal HUS, and really in related to vaccination. I will touch pathophysiology and treatment and outcome, because I think the majority will be really keen. What's the treatment? What's the outcome? What can I do better? Well, first we go. I think this is I think now in a couple of 5 years, the Lancet brings up a very broad review paper about pneumococcal bacteria, on Haemophilus influenza bacteria, and because this is still in the world one of the greatest bacterial pathogens who are leading to death in children below 5 years. The majority has pneumoniae. And I think it's good to be aware that it's really a common pathogen, which is in a lot of countries has devastating results. Fortunately, we were able, I think from the year 2000, depends which country you're in, we were more and more able, there was a vaccine becoming available for the most 7 common serotypes of Streptococcus pneumoniae. And that helped to decrease the death in children due to pneumococcal. And I think really, if you see in this vaccination period, you see the death rate is 50% less. And I think that's really very, very important worldwide. Of course, not everybody is vaccinated, but to have already this kind of decreasing the death ratio, I think is very important. Okay, this pneumococcal bacteria, I think it's one of your common colonizers into the nose. So this is in humans, and it is really specific pathogen in humans, and that has to do with a lot of characteristics of the bacteria. It's certain virulence factors that it likes to it has certain neuraminidase in as a virulence factor, which can human have a lot of things with neurominic acid on their proteins. So it really feels comfortable to be in an environment of in humans, and mostly it's the nose. It has also certain aspects that to evade complement system, for example, because the complement system wants to get rid of your bacteria. So if the bacteria has something to some characteristics to can evade the complement system, that would be really great for the bacteria. And indeed, that's possible for pneumococcal bacteria. They can really recruit factor H and then be protected for for death for themselves. So in the nose, there is you can transmit it by shedding. It can be in the carrier itself. It can invade the host either by aspiration, mostly then causing pneumoniae. It can be local spread, so that's in the ear infection, otitis media infection, and it can be also given bacteremia, which can lead to meningitis and sometimes also to pneumonia. So I think that's the root of the bacteria. And this is the virulence factor. Well, the bacteria, it's a diplocoque, so you can see it over here. It consists of a capsule, and mostly the capsule, this is where we relate the serotype on, because you have hundreds, I think about 100 of serotypes of pneumococci, and they are built up of capsule, a cellular wall, a membrane. And if you then here on the right, you can see there are a lot of virulence factor. For example, there is a virulence factor here, neuraminidase. I will touch on it later. There's pneumolysine, also a very important virulence factor. And this is built up. This builds up every pneumococcal bacteria. Okay, here you see the various virulence factor, and the capsule is important because this is the determination for the serotype. Okay, this we now know, but when it becomes invasive, when does this pneumococcal infection, when it's just as a common colonizer there in the nose, and when does it become invasive? So there are risk groups we know that children below 5 years are of risk, and elderly people, and that's also where the vaccination schemes are put their emphasis on. You might be more at risk if you have a previous influenza A virus infection, and just a couple of days or weeks later you become infected of the pneumococcal, gives you more harm. It can also be any respiratory tract infection, doesn't be particularly the influenza A. Immunocompromised patients with chronic diseases, so as we know, the kidney patients population, and big cohorts looking at see that lack of breastfeeding, malnutrition, exposure to smoking gives also a risk for pneumococcal disease. Oops. And then I have another questions for you, as you are still an experienced audience. I would like you to know if you could you tell me what is the most presentation you see, and because it's an invasive, the pneumococcal then now becomes invasive, and some persons will lead to HUS. So is it mostly they present with meningitis, those patients first, or pneumoniae, or bacteremia? So I would like to hear what your opinion is, and we will touch upon it later.
Yeah, I've just started the poll question, so it's like we've got 15 minutes left.
15 seconds left, I hope.
Yes.
Sorry,
okay, otherwise we run into trouble. Yes. Okay, so think of your patients which you had, and what was the presentation? Probably the majority you met on the ICU. That would I expect. At least that's the majority where I found my majority of pneumococcal HUS patients. I was called to the ICU and then asked if this patient could have a pneumococcal HUS. Let's see what the seconds do. The final countdown.
Yeah, I've closed it.
Yes.
Yes, and the results are 7% for meningitis,
Yes.
76% for pneumonia, and 17% for bacteremia.
Ah, well, keep that in mind. But I think we have a very good audience. Well, in time, I think now in the 25 years, I mean, and even earlier for the polysaccharide viruses vaccines, there are a lot of vaccines developed. And you can see here the various serotypes. I think those are the polysaccharide vaccines, and these are the capsular vaccines, the PCV. And those are the ones who are often used in the beginning. It was the PCV7, and I think it's not even existing anymore, but or maybe I can find it in this table, and those are the serotypes against it, and I think that's important to know. And I think what people saw in time, that while having one vaccine already there, for example the PCV7 with 7 serotypes there, that non-vaccine types emerged and give more trouble in clinic. This is from the ECDC from Europe, so the European Center for Disease Prevention and Control. A very busy slide, and you can see if your country is on it. I mean, you see that nowadays the majority have a vaccination program there in the very young, in the first year. Mostly it's 2 vaccinations, sometimes a 3rd vaccination, and then there's a booster afterwards. And then you have a vaccination program in the elderly. So this is, and it can vary per country. If it's 13, the PCV for 13 serotypes, for 15 serotypes, for 10. So you should ask yourselves what happens in my country. For example, I know that in the Netherlands now here there's PCV 10, and I know that we have just switched to the PCV 15 serotype, so it can change. Well, we are here for the hemolytic uremic syndrome, for TMA, this pneumococcal causes. Of course, we know hemolytic anemia, thrombocytopenia, and organ damage. We know that in children, we have many forms of TMA, and here the majority of the forms, I think the most well is the STAC HUS. We have the TTP there, we have the atypical HUS, complement-mediated. We have the Streptococcus pneumoniae, and we have the secondary TMAs there. I think the Streptococcus pneumoniae, because of his presentation, is mostly somewhat easier to recognize. And in the big scheme, and I always like this picture very much because it's adult and children causes in the whole scheme, but it's the infection related. There's the pneumococcal HUS, and that's what we mostly in children see. Then I would like to ask you what is true. I mean, I have 4 polls questions, so don't be afraid that we only have poll questions here. But this is the third and the pre-last question. What is true to your opinion and to your experience that the pneumococcal HUS is more common than staph HUS? That the pneumococcal is more common than TTP? That the complement-C differential is more common than the pneumococcal HUS? Or that oh, that's the same. I see that C and D is the same. So I would like to, so C and D doesn't matter, it's the same. So it's A, B, and C, you can choose. And I would like to start the poll by the organizer. And I wonder, I don't know who my audience is, but I wonder if you know in your country, for your population you have in your hospital, what the incidence is. I think sometimes it's very difficult to have an incidence on these rare diseases. That's where we have registry, an ERKNet registry. And I looked at the ERKNet registry actually, and there are 30 cases. I mean, last October we had 30 cases of pneumococcal HUS in the ERKNet registry. So that's, and we have 600, so I'll give you already a clue now, on staph HUS. Anyhow, and let's see if there are some seconds left.
Yeah, it's nearly done.
Nearly done. Okay.
Now.
Then I'm looking forward.
So we have a clear result here as well. I'm very happy that answer A is just 6%. So staph HUS is apparently more common in most places than pneumococcal HUS. We have 81% for pneumococcal HUS is more common than TTP in childhood, and another 10% for complement-C deficiency more common than pneumococcal HUS. Yeah, it's good to hear, but I also think one has to realize, I don't know my audience in which country they live in, because if you live in a country where staph HUS is not very prominent, you might see more pneumococcal HUS. So I don't know if A is wrong, depending on the country and the area you live in. But for me and for Jens and for Western Europe, I think that pneumococcal that B is the right answer. That pneumococcal HUS is more common than TTP. Well, what is in general already thought for years, I think it's going back for the before 2000 and 1970, 1980. That we already knew that this streptococcal pneumococcal produce neuraminidase, and they secrete this neuraminidase, and for this it can then. This neuraminidase can decellulate the neuraminic acid, which is on the glycocaine protection on endothelial cells, on thrombocytes, on erythrocytes, and also on plasma glycoproteins. And here is an example there. So those little Pac-Mans here, they cleave. There's a protoglycan layer on your on the endothelial cells, and it cleaves this neuraminic acid from it, and it and that becomes then, what then happens is this little stick over here, that's a CRIP antigen. It is called the Thomson-Friedreich antigen. And when this is not hidden anymore, the majority of us have or will have antibodies against this CRIP antigen. And when this CRIP antigen then connects with the Thomson-Friedreich antigen, you get an activation of your cells. It could be endothelial cells, your thrombocytes, your erythrocytes. You get an activated cells, and the cells get disturbed, and you will end up having a thrombotic micropathy. And you will also have a disturbance in your plasma glycoproteins carrying neuraminidase. And this might help sometimes for your diagnostics. Your diagnostics is indeed, like I told you, the majority will be on the ICU already. Cultures have been taken, sometimes difficult because patients have already came ill in so quickly that antibiotics were already given. Could be the case. We have another option, pneumococcal antigen in the urine, if the patient is still urinating, which can help you. But this is very important, the fibrinogen and coagulation test, because sometimes
it's also for intensive care doctor, also for you, difficult. Is this a patient with a TMA with a disseminate intravascular coagulation, or is it a pneumococcal HUS? And for that, you need the fibrinogen and the coagulation test. You perform a direct Coombs, and then with that you test actually the binding of this anti-T antibodies to the T antigen, which is on the red blood cell, and you can see indeed if this is positive, it might help you to make the diagnosis pneumococcal HUS. There is also in the older years used a peanut lectin agglutination test, where you use a peanut agglutinin, which is a high affinity of this Thomson-Friedrich antigen, and gives then a positive agglutination when tested on cells. But this is not, I think it's only, actually, when I wanted to use it in the Netherlands this year, I could not even do it anymore. Even a specialized lab didn't have it anymore, or didn't know how to do it. So I think I probably should have been a question to you guys if you still use it, but it is in the literature a lot of times mentioned. You could also use, but then you need really specialized labs. You could look for neuraminidase in the blood. For example, here in the Netherlands, we can do it in Nijmegen, but that's specific. It's not possible everywhere. And you could use the temporary effect of the neuraminidase taking off this the neurominic acid, so decellulate your proteins. And you could use it, for example, and then I did it already 20 years ago with transferrin. Transferrin is has sialic acid on it, and when there's neuraminidase there in the blood, it will decellulate the transferrin. And this is a patient here with HUS. So you have a different pattern then, and then means that there must have been neuraminidase there. This is an old technique. This is an SDS page, so I think this is really absolutely not for the clinic. But nowadays, mass spec comes in as well. And for example, for transferrin, here you see the different trees. You can tell, and the end is always a neurominic acid there, or sialic acid there, which will be cleaved then in the neuraminidase is there. And then you get a certain profile there, which the specialist in the clinic, the chemist can read out. So that can help you. If you think, is there a neuraminidase there? Is there a pneumococcal there? Then it is a very fancy technique to help. Definition. This is important if you want to define very clearly if you have a pneumococcal HUS. It's a definite case when there is TMA there, when you have indeed got your pneumococcal there, and we have absence of disseminated intravascular coagulation. It will be more difficult if you have evidence there for DIC, but it will help if you can find evidence for the T antigen activation. We call it then a probable case. And if you have less evidence, so you cannot find the bacteria, and that can often be the case, you should call it then a possible case. So the incidence is difficult, and no good data there. Old literature, different classification. In the old days, everything was called atypical HUS, but we know can classify it more better. But there are some in the USA has some incidents there. There's a cohort in Utah which has this incident, and then the UK just had an incidence of 0.25 in the beginning of 2000, the first years, but then later on with a very different vaccine, they could lower it. And then I thought of my own population in the Netherlands here, and then that's was also why I made a poll for you guys, that stack HUS in the Netherlands is still the majority of TMA, and the complement is second. The pneumococcal is probably the third, and then it comes as very rare cases over here. So that's good to know, and it's good to know for your own population, and might be different than from the Netherlands. These two cohorts, which I show you here, really beautifully examined. This is a cohort when there was no vaccine there against pneumococcal, done in the GOSH people, and there is a cohort there recently when there was a couple of years, so 4 years of PC vaccination for 7 serotypes, and later on for 13 serotypes. And let me tell you about this cohorts. This show you that really indeed the majority is below 2 years. And the majority indeed has pneumonia. It doesn't matter which cohort you're looking at now, if it's Waters or Maguana, but it's indeed a pneumonia, and that's what the majority, have chosen in the poll. The majority of those cases have empyema. They think that why it might be those are worst cases, because those cases then they have probably more neuraminidase release or more virulence factors release and give them leading to HUS. And there's still a quite big group of meningitis there. And from this group, there's quite a proportion which has cerebral abscesses. And you can also only have bacteremia. I think in the Waters cohorts, they really could identify the pneumococcal in 80%. That's not always the case. It's sometimes be difficult. And also when they used the T activation assays, they found really the majority had T activation there. There might be an underlying morbidity. That's what was the later cohort in the UK showed us. And there's quite a mortality there. And the mortality is not due to the HUS or the TMA, but the majority is mostly seen in patients with meningitis. And that is good to know. Serotypes, you can see before 2005, the serotype 19A was there, was the majority, but it was still prominent in the cohort of Maguana, and I will tell you more about it. This is the cohort, the latest cohort from 2005 to 2016, 10-year cohort, and somewhere, I think it started over here, the PCV vaccine serotype 13 was introduced, which also vaccinates against the serotype 90A, because before you see that there was a big group of 90A there, but later on it was still the case, although the vaccine was already there. And we could, and also important, and that's with every vaccination population you examine, you will still identify non-PCV pneumococcus strains occurring. And you will identify that there are PCV serotypes there which you vaccinated from, but was still causing pneumococcal HUS. Might be that the vaccine didn't work that well, or for example, for the 90A, is reported in several reviews that this serotype has a higher nasal carriage. It might be less susceptible to penicillin and maybe a more bigger producer of neuraminidase. So it pops up several times. If you then ask me, okay, the serotypes, does one serotype cause more pneumoniae or more meningitis? I think we cannot say that. I think the 90A, for example, causes pneumonia. The purple one is mostly pneumonia, lower respiratory tract infection. The meningitis is the green population. And you can see that serotypes pop up in pneumonia, but also in meningitis. So the prevalence, mostly 2 years, under 2 years, that's what I told you there. And what I also want to stress, you already have a pneumococcal infection or you have a meningitis, and then between 3 and 13 days, TMA can occur. Sometimes hepatic involvement is there. And so that's good to know that there is a delay before you develop TMA. And of course, good to know is that there is no recurrence, just like the stack HUS of pneumococcal HUS further on in life. This is a nice study done in the USA, which wanted to identify, okay, we have in all these years, they really looked for a long time. I haven't put the years there, but it was really quite a long time. And they looked for pneumococcal HUS and other causes of HUS. And then they found that the pneumococcal HUS had a longer stay in hospital, a higher mortality, especially when there was meningitis involved, had needed more dialysis and had more ICU and medical ventilation. This is a slide I took from a recently published, just this year published, a New Zealand cohort where they investigated the invasive pneumococcal diseases in time with the various pneumococcal vaccinations they had. And then suddenly here they switched to another vaccination which didn't have, which they thought had, that was here, this one, the PCV10 one. They thought it was protected against serotype 90, and the 19F, which is one of serotypes 19F, was just maybe protective against 90A as well. But it turned out that it was not the case, because people were less protected and they had to switch again to PCV13. And then there was, this was all the people in this course were children, and you can see all the serotypes here. And there was 7 times also hemolytic uremic syndrome, and indeed the majority all had them 90A and all had empyema. Come to pathophysiology. I think still it's not well understood. We know that from the invasive pneumococcal infections, it's 4 into 1,000, 6 into 1,000 invasive pneumococcal infections will progress to pneumococcal HUS. So it's rare, really rare. And we know that neuraminidase is there in every pneumococcal HUS isolates and also in non-pneumococcal isolates. Every pneumococ just has the ability to make neuraminidase. And so other factors are needed. And you can see here other neuraminidase. We know there's neuraminidase B, which quite, I think it's more than 90%, between 80 and 90% of the isolates, pneumococcal isolates have. And there is neuraminidase C, which I think has a less, I think 50% of the pneumococcal isolates. So is this then the difference? Could it be the host factors? For example, the way we react on complement dysregulation. Could it be the microbial factors making more, not only neuraminidase, but also pneumolysine, for example, or PSPC? Or could it be the combination? I think we still don't know yet. So that, but it's important to get to elucidate this more and more, because one, we want to treat our patients with a pneumococcal HUS, and for that I have made this poll. So I would like to think of how you have treat your patients. Is it supportive? And then I mean, of course, you have your antibiotics, and you have your fluid management, and you have your erythrocyte infusion, thrombocyte infusion maybe, and there's plasma exchange, you add to it, eculizumab you can add to it, or you can add a neuraminidase blocker. So I'm looking forward to hear your opinion or your way of treatment.
The poll questions are started.
Yeah, and it could be very well that you switched in time, but then maybe you choose what you do at the moment. And I can tell you there's no wrong or no good, so don't worry. At least I think there's no wrong and no good. It's almost done, I guess.
Yes, it is. Now we just got the answers. It's a bit more than 50%, 53% for just supportive therapy, 24% for supportive and plasma exchange, 18% for supportive and eculizumab, and 4% for supportive and oseltamivir.
How much was the last one you say?
4.
4. Okay, thank you. Well, it's also if it's available. I think that's also important to realize. Well, I think supportive, of course, we all agree that this is what you need to do. So appropriate antimicrobial therapy, your fluid regulation, erythrocyte infusion. And when you then look in literature, you find that you need to give washed packed cells. That means cells who are a little bit more pure, because sometimes they contain a little bit of plasma there. And in plasma, the antibodies against the Thomson-Friedrich antigen are there and could make it worse. That's also for the fresh frozen plasma. Of plasma infusions, you have to think about that. Avoidance of thrombocyte transfusion, that's I think for every TMA, because we think when the cells are activated, especially the endothelial cells and the glomeruli are activated, you can easily have more thrombi forming. So if needed, you do, but if you can avoid it, you don't. And of course, renal replacement therapy when needed. Then we have the options, which are all discussed in literature: plasmapheresis, complement inhibition, and inhibition of neuraminidase activity. For plasmapheresis, it's not a rare thought. You could remove or reduce your levels of anti-T antigen antibodies, and that will help, hopefully, to change the pathophysiology. You could remove or reduce the neuraminidase there, so preventing neuraminidase cleaving neurominic acid from proteins, from cells. And those are never, this plasmapheresis is never studied very well. I mean, people have done it because of the logical thoughts behind it. Those are case and case series. And of course, the concern is when you use plasma that you need plasma which has no anti-T antibodies there, because maybe they're worsening the pre-existing hemolysis. And if you ask the people, so the evidence is not really well, and the American Society of Apheresis says, well, there's insufficient evidence of efficacy and risk of benefit. I've never done it because of the concern, and the reviews, and Bernard Kaplan from the United States has a review, and then there's another review of Agarwal there. They, with all the literature in it as well, it's in the Pathogens, a very good review, so I would recommend it to read it. They say there's insufficient evidence. Is there an evidence then for complement inhibition? I can clearly tell you by my experience to examine the complement system in STAC HUS, atypical HUS, and pneumococcal HUS, that if you look for complement activation products, so for the alternative pathway, for example, it's really pneumococcal HUS have the highest levels of activation products there. So it's a really there. You can find low C3 and C4 in the blood in the acute situation. It doesn't need to be, but it's often it is. And if you look for genetic variations, then I wonder, I see in the literature a lot of genetic variation reported in case and case series, but if they are pathogenic or likely pathogenic, like we know that an atypical HUS have clearly a role then it for pneumococcal HUS, I don't know, it might be very, very low. Like I said, it's case reports, here are some there. And really, if we think that C5 inhibition, like eculizumab is, for example, has a role, then future studies are needed. I don't know, because I think you can say, okay, if there's so high complement activation, then inhibition, it might harm, and inhibition might help. But this complement activation might also have a role there, to get rid of the bacteria, to get rid of the so it might be a dual sword, how they call it. Then another option mentioned in literature, and sometimes you see abstracts for it as well. If the neuraminidase is there and causes a lot of harm and induces problems on cells and on proteins in the blood, you could think of neuraminidase blockers, who are developed for the influenza, to treat influenza A virus, so not the bacteria, but the virus. But might they be useful in bacteria, for example? Well known is, for example, oseltamivir. I think in some abstracts you see it. It sounds logic, but I think we really need studies for that. First, is the treatment for virus the same as for bacteria? It's the same neuraminidase, for example. So we need studies for that. We know well, of course, that those blockers are used in influenza A virus, also in children, but we will have to see. Well, then I come to my take-home message. Very, very rare. I hope I have seen you with the incidents and also with the studies that it's rare in childhood still. And it is also rare to go from an invasive pneumococcal infection to develop HUS. Vaccination has really lowered the incidence. However, still the PCV serotypes are found also these days. They still pop up, and as well as non-PCV serotypes. So we still have to look carefully into these profiles and to follow the vaccination advices from our colleagues in infectious disease and immunology. The presentation might be less difficult than other forms of TMA. They're more recognizable because of pneumonia and because of meningitis, but are more the difficulty here is to differentiate between disseminated intravascular coagulation. We have some tools there, the direct Coombs test, which is not really 100% always sensitive, but can give probably it range between 60 and 80%, but it can be of help. You can look for more specialized tools like mass spec for neuraminidase activity. And of course, we still have the supportive treatment, and we still are needed for trials for other options which come forward by looking more into pathophysiology investigations. And with that, I think this is Nijmegen by night. I would like to thank you, and I would really be happy to answer questions or discuss questions with you. And I hope you liked the presentation.
Thank you very much, Nicole, for this fantastic presentation. And I indeed would like to discuss this topic with the audience. And so far, I can't see any questions in the chat yet, but I'm sure there'll pop up some. In the meanwhile, may I ask you and start with a question? You mentioned that there's a clear peak of patients below 2 years of age.
Yes.
What are your ideas about that? Are they just more prone to the neuraminidase theory or part, or is it because of a lack of vaccination still in that age?
Might be multiple reasons. I came across one paper, an old paper, who said that very young children don't have yet these antibodies there against the Thomson-Friedrich antigen, and they make them when they have that invasive pneumococcal infection and the crypt antigen comes free, then they have a very serious reaction for that because it's IgM antibodies. I don't know if that's the case. In those cohorts, I mean, there might be patients who are still not vaccinated, and that's for that develop the disease, but also those who are vaccinated can develop disease. And it might be that then the response is to the vaccine is not as, it's vary from person to person, might be not that optimal, or there might be comorbidities who make them not that optimal. There are various reasons for that, but that's not really a clear clue, I think.
Okay. I was also, oh yeah, sorry.
Sorry, I just want to mention that there are questions, but in the question section. I don't know if you can see it, Jens, but sorry, if not, I can read it out.
Can I see them as well? I don't think so, huh?
I'm not sure.
Vanessa, maybe you can read out the first ones, because I don't see them yet. I try to fix that.
Yeah, so I think it's split into 3 parts, but it's one, I'm not sure. So it's the first one is, it's limited to children or adults also. Vaccinations for it can prevent or not mandated. It's related to infections with or without vaccination. I'm not sure.
It can occur, like I said, it can occur in definitely in more at risk are those who are not vaccinated. I think the UK has clearly shown, and also the New Zealand study, that with vaccination and change it appropriate to the serotypes who are circulating and give invasive pneumococcal infections, that's by adapting then vaccination protocol, you diminish your invasive pneumococcal infections, and for that also the HUS incidence. So that's clearly the case. In adults, I think the immune compromised adults, there are not many reports on that, I have to admit, and maybe I haven't looked at it very carefully, could be as well. But I think above 65, invasive pneumococcal infections can really be of harm for the more older population. But I have in my 25 career, not here in the Netherlands, seen a pneumococcal HUS in adults, but doesn't mean it hasn't existed. Or maybe they can develop invasive pneumococcal infections, heavy ones, but not HUS. There are not good data for it. And if anybody in the audience knows patients and has data, please let me know.
Okay, thank you, Nicole. Second one, it's all from the same person. Immune system longevity after vaccination or infection, how long? Need to repeat vaccination after how long?
Yeah, I think you have to follow the regular vaccination protocol which is for pneumococcal, which is I think in the majority in every country, which I think the children are at risk. So and below 5 and especially above below 2. And then I think they get somehow have developed antibodies or have the immune system. It's more adapted to the various serotypes. That's why I think there are some, and I think those immune compromised and with chronic diseases, then it might be valuable to revaccinate. But that's in general to prevent invasive pneumococcal infections in general, because they harm those patients very much. And I think that's mostly the local protocol, the national protocol there is. In general, I have never seen a publication where a person that had in childhood a pneumococcal HUS and developed later on again a pneumococcal HUS. So I haven't never seen a publication on that. I never heard about it. But in those children we take care of as well. So the immunocompromised, waiting for on dialysis, waiting for a kidney transplantation. I think those you need, depends on age. You need to ask your national or your local team. You need to revaccinate them, because it lasts for, I don't know, but a couple of years, but sometimes not more than 10, 15 years. So that could be good to ask. I'm not a vaccination specialist, unfortunately.
Okay.
There are a few questions about, I found them right now, sorry very much about this.
Right. Yeah.
There are a few questions about plasma exchange and plasma therapy, which is rather plasma exchange probably. Whether you would use rather albumin instead of plasma when doing plasmapheresis, and same thing about in older patients. Are there data about immunoabsorption in these patients?
I have not seen data on immunoabsorption. Might be not a it's not a rare idea actually. I've seen data on albumin plasma exchange. I mean, and that was mostly data from a cohort in the United States. It didn't still they didn't find that it was beneficial, and probably not really good ruled out if it was really beneficial. So, but there have been groups who have used albumin, but found that it was not beneficial in general. But this immune absorption is not a bad idea, but nobody, in my opinion, has looked for it. And you have to, yeah, okay.
Sorry, didn't want to interrupt you.
No, I think what would be then the right moment, because mostly there will be already a lot of damage done, and so difficult to find the right moment. What is the perfect moment to do this then?
Okay.
Okay.
You mentioned eculizumab, and there's one question from Magdalena Blasiak about eculizumab and your personal experience. Have you used it ever in your patients, and what was the outcome?
I've not used it in my patient because it's not reimbursed in the Netherlands. I can only use it for atypical complement-mediated HUS. I've looked through the cases reported in literature, and there is, for example, in an adult, 53 years, and the references in the presentation, there was a patient which was really very severe pneumococcal HUS with also extrarenal manifestations, also from the skin, and they found a remarkable improvement. Yeah, all these in most series mention a good improvement, but if you look on, it's difficult because it's there may also be an improvement without eculizumab. You don't have a trial for that, so that's always difficult to say, and it might be in days and weeks the same you could have expect with giving no eculizumab. So I find it really difficult to answer this question if it has a benefit, and I'm not allowed to use it in the Netherlands. Yeah.
Then there are two practical questions. The first one is by Lukas Bergerhausen here from Münster. Does a negative direct Coombs test rule out the diagnosis of pneumococcal HUS?
No, I don't think so, because the sensitivity is not. You can find it not in 100%. That's what the literature tells me. In the majority, in my patient, it was always positive, but literature tells me that it's not always the case. And for that, I think it can be helpful to, hopefully, if there is a urine, to do a pneumococcal antigen test in the urine. Or if you really are in doubt, you can also look for neuraminidase and the change in glycosylation pattern, which I showed you. But those are very specialized tests. I think maybe you end up to say that might be a possible case of pneumococcal HUS then.
Right. And then there's another question by Abdelhamid Hamdi Ramadan, who asks when to biopsy kidneys in the setting of pneumococcal HUS.
In my patients and the children I've seen 10, I never biopsied them because I think in the acute phase, after having an invasive pneumococcal infection on the ICU, having a pneumoniae, having meningitis, then there was, you will find clearly, if you would do so, I mean, if the thrombocytes allow you to do so, and if the uremia allows you to do so, you will find thrombotic micropathy there, but you cannot discriminate. Probably the clinical presentation already points you that it will be a pneumococcal HUS. So when it might be later in time, if you have chronic damage, you want to see if the proteinuria doesn't go away, maybe, but later on you want to have some reflection on chronic damage, but in a chronic sequelae, because that's what I didn't touch about. You have actually this, of course, the mortality in the acute phase, but in the long term, and I forgot to put it there, I realized 20 to 30% have chronic renal sequelae, and then it means some have some renal insufficiency, but a mild CKD, or but there is hypertension and proteinuria, just like in the STEC HUS. The same amount of chronic sequelae you can have. So you have to follow up your patients, and that's what I didn't mention, and I apologize for that. But I see them every year. But that is for every acute renal insufficiency where I do perform dialysis. We see them every year to see in time when they grow up and have hypertension and proteinuria can still pop up. So that's what we do.
Mm-hmm. That's what we do as well, but I was always wondering, is it actually the same as in STEC HUS or not? But
that's
apparently you would say it is, yeah.
Yes, that's what they. But what I saw in the cohorts, I mean, there are not many big cohorts, but that's what they report: 20-30% sequelae.
Okay. And finally, here on the chat and question box. It's rather a recommendation than a question, and it's by somebody very, very experienced, Johan van der Walle, and it's always a good idea.
Thank you, Johan.
The suggestion is all that therapies that you mentioned have no evidence-based data, or are no evidence-based data. So all the centers follow their own case-based protocols. And he asked, wouldn't it be preferable to draft a protocol that everybody is following and the same protocol, and then we use the registry to follow up and analyze these data?
I think if you really want to do so, I absolutely agree. And we are now in Nijmegen. We are examining the neuraminidase blockers, oseltamivir, and if they could be worthwhile. And I think this would be really a good candidate, one of the candidates. But if you want to study one of these, I mean, it might be not as expensive as C5 inhibition, but I think what Johan says is really important. I think that's where the ERNs are for. I think to make a protocol like that, and hopefully we can all then put data in and monitoring the data and look indeed if we find differences. Good remark. Oh, good recommendation, of course.
Yes, and I guess with this suggestion by Johan, I have a quick look on the questions, but I don't see any further new questions. In that case, I would actually like to thank you all for your questions, for your interest, and most of all would like to thank you, Nicole, for that fantastic presentation and for answering all our questions. And I have a short question to Vanessa. Do we have a slide with the next webinars as well?
I'm not sure. Normally it should be included in the presentation of the speaker, but Nicole, you have not prepared anything.
No, I'm sorry. No, I haven't done it. So
okay, sorry.
I'm sorry for that, but I have something in mind that on the 7th of February there's the next webinar, I think, and I read it this morning. I can't recall what it was about, but it was very interesting. So I invite you all to participate again in 2 weeks' time, and looking forward to see you there. And thanks a lot for your attention right now. And thanks, Nicole.
Thank you for having me.
Yes. Yeah. Bye-bye.
Bye.
Oh, thanks.